Okay, so we're going to go ahead and get started with the second session. So co-moderating this session with me is Dr. Soto. Our first speaker is Dr. Jose Diaz. He is a professor at Vanderbilt University. I've known him for many, many years during his days when he was with the University of Michigan, and he's one of the foremost leading experts on basic science in terms of venous disease. So Jose is going to give us a little talk on animal models.
Thank you, Dr. Papas, for can you hear me? For the kind introduction and for the invitation. Let me see, go forward. The title of my talk is Pathophysiology of Venous Ulceration and Animal Models, what we have learned, and I don't have any conflicts for this talk. So in order to try to explain basic science concepts to the clinical audience, usually two outcomes are possible, or this will become very interesting or very boring. So I will try to see if this can be very interesting for you. The way that I put together this talk is try to answer a question, is CVI is a venous problem, is it a skin problem, or both? So what we know is that venous hypertension is the proposed mechanism that leads several changes related to the superficial veins, related to physics, biology, including endothelial dysfunction in the biological component. So what you will see is a cartoon where in the top is a representation of a vein with venous hypertension. And in the bottom, you can see the skin and the dermis, which I will call at this a happy skin at this point. So secondary to venous hypertension, what we have is macromolecules and red blood cell extravasation on the dermis, and the skin doesn't like this very much. So inflammation reaction is secondary to this new environment that generated by venous hypertension. This will lead to inflammation, and the chronic inflammation will set monocytes in this new environment. Now, monocytes outside the circulation become macrophages, but also it produces TGF-beta. This particular molecule leads to what we call, or we learn, as CVI-induced dermal fibrosis and tissue remodeling. And what it is that a stimulation of more production from fibroblasts, local fibroblasts, in collagen in the local area. But also collagenases named MMP2 and 9 will produce this tissue remodeling, which is very interesting, but affecting the vein wall and the dermis, this new situation. Now, I would like for you, I will not go in details in those molecules. However, I will really point your attention in this new environment. We went from a dermis that is normal, but now is altered. Now, up to this point, we have evidence that CVI is a process that affects both vein wall and skin interface in a chronic remodeling phenomenon. So let's talk about the ulcer. First of all, the healing process at the molecular level. We know that normal repair is responsible for initiating this stimulation of fibroblasts, as we saw in the previous slide also. But particularly when we have a lesion, there is a response called fibroblast-mediated matrix contraction, which is very important because it's not only the production, but also this physical property that this remodeling brings, which is called construction. So there are two types of healing processes that are not normal. The reduced fibrosis would lead to the fibroblast-mediated matrix contraction failure. So the tissue fail in this contractile situation. But also, we have an excessive fibrosis, would lead to the process of hypertrophic scar or keloids, in where the fibroblast-mediated matrix, which is the production of those fibroblasts, is called contracture, not contraction, so it's increased. The normal process of healing is set as hemostasis, inflammation, proliferation, and remodeling, 4 phases that go from injury to healing. And if this is a skin, and this triangle represents an ulcer, I will try to put very quickly the main phenomena of repairing. Platelets, as the main driver at the very beginning of this, lead the hemostasis phase with the production of coagulation factors, growth factors, and fibrogen, leading to the production of the fibrin clot that we can see in the ulcers. This is called provisional matrix, and this leads to the second phase, which is the inflammation. Now, this phase are led by three cells: the mast cells, neutrophils, and monocytes later on. Mast cells are responsible for the heat, edema, and pain, and this will lead to the inflammatory phase. Now, in this particular moment is when the proliferation starts. Fibroblasts are stimulated, as we saw in the previous scenario. This is an ulcer. However, the production of collagen is sitting there, and the modification of that collagen is for the MMPs, as I mentioned before. The results of this is that we have now a collagen fibrin matrix, as I mentioned before, that replaces this provisional matrix. And here it is, the last final stage in where the remodeling will lead to granulation and epithelialization and tissue contraction. This is a normal process of healing in any type of lesion that we can observe at the dermis level. Now, when we have a deficient healing process, what happens is that inflammation, proliferation, and remodeling are delaying the healing. And the cartoon probably will look something like this. We have metabolic activity that increase and decrease in the normal scenario, but in this case never decrease, because inflammation and proliferation are prolonged in the time. In this particular scenario, with deficit in healing, we don't have granulation, epithelialization, or tissue contraction. So the question will be, why we have this non-healing process? Well, it's quite interesting if you think that the dermis in this particular scenario, when we have underlying venous with venous hypertension, if we induce an injury here, well, probably in that scenario is responsible for that. But also, later on, we also observe that macrophages that are classified in M1 or M2, the bad guys and the good guys, participate in this chronification of the situation, because what is interesting is that macrophages clean up everything that is coming and is not from the dermis. Red blood cells are one of the cells, and what happens over time is that if I keep venous hypertension, I keep red blood cells going outside of the circulation, and that produces a situation, local situation, named iron overload, that make the M1s really mad, if you allow me to say that. So finally, how we get this, or how I understand this, using animal models. Animal models, we need to say three things are important because apply to all animal models. Most of the models do not replicate the 100% of the disease. All models have advantages, disadvantages, and applications, and sometimes it's necessary to choose more than one model. You will see that there are CVI models and ulcer models in animals. So let's talk about the CVI ones. We can classify these animal models in three types: ligation of a large veins, fistula between the femoral artery and vein, or occlusion of the mesenteric venule. So in that particular scenario, you can see on the right pictures from different manuscripts that highlight the different techniques possible. But what they have all in common is that the target mechanism is venous hypertension. You will choose the different animal model, depends on the research question that you have, and all of them can help to understand what CVI is about. Now, in case of the ulcer models, we have several models too. I bring to you guys this review article that's outlined very nicely and different animal models and features of those animal models. You can see that it were developed in rabbits, mice, rats, or swine. And what is interesting about this manuscript also is that there are two tables, one outlining these advantages and disadvantages of each of the models, and also another one that is very interesting, showing skin thickness and hair density in all species, including humans. Now, one very interesting model that was recently developed is this mouse model of iron overload. What it is that injection of iron intraperitoneally in rodents for 3 weeks, and then perform ulcers of the same size in those animals. Why this model is interesting and why this macrophage I mentioned before was studied is because when with this model, it replicate very closely what happened in ulcers in humans. In this particular work, they took sample from venous ulcers in patients, and they compare with this type of ulceration in these settings of iron overload. And what happened, as you can see in the pictures on the left, first of all, with iron, the ulcers didn't heal very well, but also there is a very close parallelism in iron content of the macrophage 1s between ulcers in humans and this model. So in summary, there is biological evidence showing that CVI is a vein skin chronic process. Biological mechanisms have been proposed for the lack of healing in venous ulcers. Monocytes and these macrophages, M1, secondary to iron overload, participate in the tissue remodeling involving vein wall and dermis. There are several animal models to study CVI and ulcers, but we need to choose more than one sometimes to understand the entire picture. And remember that choosing the model is better to choose the model following the research question. So thank you, Dr. Papas and the organizers for the invitation.
All right, we're going to bring Nikos back. You've seen his enthusiasm for his specialty. Something that I think is wonderful is that he's a friend of CVR, and his excitement in education is matched well in the lecture series that he is a guest lecturer for our fellowship program. So, Dr. Labopoulos.
Thank you so much. Jose, that was a great lecture. Actually puts into perspective what I'm going to talk now. The original title of the lecture was, reflux patterns or venous ulceration, but after talking with Peter, we put it like on all the factors that, affect, the ulcer development. Have the slides on, please? Oh, no, it's going to, that's not mine. Okay. So, as you saw, venous ulceration, honestly, is multifactorial venous disease. It is very naive in 2024 thinking an ulcer as reflux or obstruction on its own. Here you see a nice image of reflux on the left, obstruction on the right, but what you're missing is what, Dr. Diaz told you earlier, the macrocirculation. Believe me, if there is no changes in the macrocirculation, no matter what kind of reflux or obstruction you have, you never get an ulcer. And you get the changes that Dr. Diaz mentioned, the changes have to appear in the macrocirculation. I remember when Peter was a resident, he was doing remarkable work on the area, and his work so clearly, among others, that the macrocirculation is the most important element for developing skin damage. Now, this is the things we examine. We discussed them earlier for the veins, but also we look at the surrounding tissues because some other problems may be in the surrounding tissues. And then we look at systemic conditions, obesity, physical activity, mobility issues, family history, because clearly you cannot choose your parents. Okay, and Peter got some excellent epidemiologic data earlier about it. And then, of course, the inflammation. For reasons we don't understand, and indirectly, what Dr. Diaz mentioned earlier, if you have exactly the same stimulus in different people, then the reaction or the degree of inflammation will be different among different people. And why is that? We don't really know. Do not forget that venous return is aided by the foot cuffle and thigh muscle pumps, abdominal thoracic pressure changes, and the pressure changes the right atrium. It's impeded by venous obstruction, could be intra and extravascular, venous reflux, right heart failure, obesity, and musculoskeletal issues. If you look at chronic venous disease, right, you can put the reflux and the obstruction, but do not forget to add what we said earlier, the foot and muscle pump efficiency. More importantly, the venous wall and soft tissue cellular biology, which is the key element for developing signs and symptoms of venous disease. Of course, the lymphatic compensation, beautiful work for Peter Mortimer in England. Then, of course, risk factors, genetic predisposition, at the rate of progression of disease that Dr. Papas saw us earlier in his talk. Now, if you look, the etiology, most people have primary disease. Secondary is present in about 27%, primary secondary in 8%, congenital is very rare, right? However, most patients can be treated with good clinical outcomes. If you look at people who have class 4 to 6 disease, skin damage versus the earliest stage, the first group, the 4 to 6, are older patients, have longer duration of disease, more extensive involvement, and higher prevalence of previous deep vein thrombosis. Not all of them, but if you look at the literature, people who have an ulceration, in our study, 17 to 52%, with a median value of 33%, have a previous deep vein thrombosis, and this can be, not to think about it. Now, as you see here, if you look at the anatomy, the superficial is easy to treat, but not curable, as often Dr. Elia says. Then the deep system, more successful now, but have lack of quality data. In 2024, there are 0 quality data for deep vein disease. There are studies? Yes. Do we have positive findings? Yes. Are of highest caliber? No. Not a zero studies. Don't forget about it. This is important how making decisions and how we need to be doing in the future to increase the margin of benefit on the way we treat our patients daily. What is interesting, the most common pathology is reflux. Obstruction alone is not so common. In this study, I have to admit, it's underestimated, but if it was underestimated by 50%, or 100%, or 200%, will never be more than 6%. So obstruction by itself, causing ulceration, is uncommon. Obviously, by my studies and also Dr. Meissner's studies, combined reflux and obstruction increases the odds for development of signs and symptoms, and particularly ulceration. This is the mechanism. I don't go to this, but skin damage, it would occur if venous hypertension, particularly in microcirculation. This shows reflux in a patient. That is the most common part of the disease, right? But seeing a reflux in the saphenous vein by itself, it does not examine the whole patient. Even know what's going on with the whole patient. Is the patient obese? That's lack of physical activity. That's musculoskeletal issues. That's food static disorders. Do you have a previous DVT? This is a post-thrombotic popliteal vein reflux. I want to mention this because patients with post-thrombotic popliteal vein reflux, they have high association with skin damage. Because we like to say, maybe in a naive way, but maybe it's partly correct, the popliteal vein is the gatekeeper of the deep venous system. And you see, unless you have this door broken in the deep veins, you don't get into problem with reflux, at least for developing ulceration. And this is a patient I saw you having reflux and obstruction. Do not forget that when you develop deep vein disease, because multiple veins are attacked at the same time, the deep venous disease, right, progresses faster than the superficial vein reflux. Here is the chronic iliofemoral obstruction has major impact because people are having swelling that usually extends in the thigh, but also an important condition of venous claudication, which unfortunately in 2024, venous claudication is not included in any scale or classification anywhere. And you know what? In a recent study, which is going to be published soon, we saw that venous claudication in people with femoral obstruction that be treated with anticoagulation alone, the prevalence is, the incidence is 18%. That's high. So, how people develop swelling and skin damage? Because of the problem in the great saphenous, having varicose veins, or efficient veins? It's microcirculation, my good friends. No matter what you have, if your microcirculation is intact, you don't get into trouble. I keep repeating this because it's the most important thing to remember. And here is an ulcer from an 86-year-old male. Look, with your eyes, you cannot see what you see on the light microscopy. Look at this picture. This is a problem. Unless the system fails at that level, you don't get into trouble. More importantly, I want to show you my good friend, Jones, Dr. Jones from New Zealand, produced some remarkable work, and he shows basically using histology and also near-infrared spectroscopy to check, the circulation. And actually, it shows you things that the venogram doesn't see, right? But in histology, you can see all the area from the dermis in the subcutaneous tissue, having significant, changes. And I like to show you this because I want to emphasize, I don't know why it doesn't play. Yeah. I mean, it is naive to think the saphenous vein that gives you all the problem unless this huge network fails. And this is a beautiful corrosion cast made for a patient with venous disease from Dr. Greg Jones and Dr. Andre Van Rij in New Zealand, right? That's amazing. So we have to stop being naive. We have to think the patient as a whole. Think what other problems are there, right? And see how a healthcare practitioner in 2024 and onwards, you can make a difference for your patient. Now, having said this pathophysiology, and it comes to the previous treatments that colleagues talked about varicina and other modalities, they clearly offer insights for treatment. Compression will reduce the filtration and inflammation. Right? Only one study by Dr. Bill Mastron that showed applying compression reduced multiple inflammation markers. And foam sclerotherapy is probably the only way to reach the microcirculation, because surgery cannot go there. Nothing else can go there, right? So very brief about obesity. There's a lot of work. I'm not going to tell you all these things, but I'll show you one of the patients. This female 63 has clearly a lot of reflux of the great saphenous vein. Do you think of this patient is a problem of the great saphenous vein or the obesity? The patient symmetrical problem in both legs, but one leg happened to have a huge reflux of the great saphenous vein. That has not made a difference. Look at this patient, BMI 46. So if you were to treat the great saphenous vein with this patient, would anything change? Nothing. Well, Nikos, what about if this patient, the same patient, had an ulcer on the same leg with a saphenous? Then probably would be a case, right? A better case. Start venous disorders, I talked in the previous lecture. This is a beautiful work from Dr. Padberg talking about the ankylate of motion. The less the range, the more the problem. And this is a patient with heart failure having only, just finished my time. And I don't want to take any more of your time. Thank you very much.
All right, thank you, Nikos. Our next speaker is Dr. Diol. I asked her if she would give us a little review about the European guidelines. The AVF hasn't updated their guidelines in a while, and last year the Europeans really produced a wonderful document, and Zoe's going to review some of their findings with us today.
Thank you, Peter. So as he mentioned, when I did do this presentation, I looked at the latest SVS and AVF guidelines, and those were from 2014. So that's 10 years ago, and the European guidelines came out in 2022. So we'll talk about some of that and how it relates to our previous US guidelines. So just a general overview, the prevalence of venous leg ulcers, 1% in the population and rising. In those over 80, it's 3%. Although 93% of venous ulcers typically heal within 12 months, 7% remain unhealed after 5 years. And there's a recurrence rate within 3 months as high as 70%. So cost is definitely a factor here. In the UK, $720 million are spent a year treating venous ulcers, and here in the US, it's approaching $3.5 billion. So it's definitely something we need to look into. The Europeans adhere to the time principle when managing wounds, tissue, infection, inflammation, moisture balance, and edge of wound. Interestingly, there's not a lot of research on pain control of venous leg ulcers, even though about 80% of patients report a 4 out of 10 in intensity of pain, but there's no clinical trials evaluating pain management. However, during debridement, there definitely are some trials that show EMLA cream being superior to placebo, and the guidelines in Europe advocate an overall World Health Organization analgesic ladder approach. So we're going to show some of the changed, unchanged, and those that remain the same here. As far as antibiotics, those mirror the U.S. recommendations from 2014 in that there's no evidence to support the use of systemic or topical antibiotics in the absence of infection. So routine swabbing in cultures is not recommended. However, there were 11 randomized controlled trials showing topical cadexamer, which is an antiseptic, did heal more ulcers than standard care. And silver dressings do show that it promotes venous ulcer healing. So that's an unchanged recommendation for them. Mobility and physical therapy, it does make theoretical sense, especially when you hear Nikos talking about the calf muscle pump, but there are no studies showing that it improves venous leg ulcer healing or the reduction in recurrence rate. So there can be no recommendation there. And comorbidities, Nikos just talked about obesity and ankle stiffness. Definitely we know that those are associated with comorbidities with venous leg ulcers. But a new recommendation for the European guidelines was recommending that arterial disease also be objectively assessed in all venous ulcer patients. So ABIs should be performed in any patient with an ABI less than 0.8. Full compression can be, or greater than 0.8, full compression can be used. And in diabetics with non-compressible arteries, duplex is recommended. Local wound care, pretty similar to the US in that chronic wounds should take a multidisciplinary approach. Debridement, they do outline the same forms of debridement. However, in the 2014 US recommendations, they recommended routine debridements, whereas here they're showing a Cochrane review of 10 randomized controlled trials with 715 patients. It is low quality evidence, but they concluded that there is limited evidence that debridement has a significant impact on venous ulcer healing, and larger studies are needed. And topical agents, definitely those are supported depending on the number and types of wounds. Different types of dressings are indicated, but hyperbaric oxygen, there is no evidence. These three ancillary treatments, therapeutic ultrasound, EMT, and negative wound pressure therapy, mirror the US in 2014, and that there's no clear evidence that on any of these improves venous ulcer healing, although after a punch biopsy of the venous ulcer, negative wound pressure therapy has been shown to improve that healing. Compression, no doubt, unchanged, it unequivocally improves venous leg ulcer healing. They differentiate between, they have elastic, superimposed elastic, which is the undergarment is a 20 millimeter compression with an overgarment of another 20 to 25, resulting in about a 40 millimeter pressure, and adjustable garments and intermittent pneumatic compression. So their new guideline is that they are indicating that active ulceration should use a multi-layer inelastic bandage, adjustable compression garment, and targeted pressure of 40 millimeters at the ankle. With small or new ulcers, they're recommending the superimposed elastic garments with a pressure of 40. And I think, interestingly, the intermittent pneumatic compression, they're recommending the same as the US back in 2014, which is where if they fail or cannot use any of the traditional ulcer therapies, it's indicated. So I think more research needs to be done there on the role of intermittent pneumatic compression on ulcer healing. And mixed arterial ulcers, new recommendation that that with compression therapy, the ABI less than 0.6 and a pressure of 60, sustained compression therapy should be avoided, and modified compression can be used with those with an ankle pressure greater than 40, greater than 60, and toe pressure greater than 30. With prevention of ulcer recurrence, a new recommendation is the use of compression garments, and elastic compression garments are useful in the long term. Treatment, definitely, we all know, underlying treatment of chronic disease, but the EVER trial demonstrated the need to do that sooner rather than later, so they are recommending definitely treating that sooner rather than later. And then in healed ulcers, they also see or recommend that early ablation reduces recurrence. The ESCAR trial used open ligation stripping. EVER was ablations. Thermal ablations and chemical ablations at a 2-week intervention period, and deep reflux should be considered not a contraindication for treatment. So that is a recommendation now. There's incompetent perforator veins, there's no randomized controlled trials there, but definitely persistent reflux in perforators after truncal ablation does lead to recurrence, so they are recommending considering concomitant or successive treatment of incompetent perforator veins. This is interesting in that the US guidelines don't talk about subulcer plexus, but in the European guidelines, they do say it's intuitive to treat that plexus with ultrasound-guided foam, which, as we're hearing, could actually attack the dermal plexus, so that makes a lot of sense, and that is a new recommendation for them. And deep venous pathology, definitely we overlook that, and there's a lot of data that show that Raju back in 2013 showed that there's, with an incompetent vein, saphenous vein less than 5 millimeters, and no evidence of iliocaval ablation alone, but with saphenous vein greater than 5 and iliocaval disease, stenting and ablation, and then pure iliocaval stenting alone. And the long-term 5-year outcome healing was 75% in all groups using that. And there's no data on deep venous insufficiency. Pharmacotherapy. We here in the US, we have the MPFF microionized, that should be purified, flavonoid fraction, and the pentoxifylline, the rheologic agent, and we promote the use of that. In Europe, they use also solodixide to reconstitute the glycocalyx and ruticides. I'll skip over these just because I want to point on Dr. Stephen Black's leg ulcer acceleration pathway, published in last year in the British Journal of Surgery, where taking on that idea that EVRA highlighted early intervention, but they excluded ulcers in the EVRA greater than 6 months duration. And deep venous outflow obstruction may be a cause of a lot of that. And also they wanted to evaluate the blockades in the treatment for the system. And we can see many of these same blockades here: lack of training, people don't know where to send the patient, they end up going to multiple different locations before they actually get to where they need for venous treatment. So they used 110 patients that were prospectively enrolled in the accelerated pathway compared to a retrospective group of 183 patients. Both groups were matched for age, sex, and ulcer size, and 54% of the patients in LUPA had a prior history of DVT. And what they found, they did do ultrasound and MRV, and the LUPA patients, 61% underwent SVI treatment and 30% underwent treatment for deep venous obstruction, whereas in the control group, only 9% of patients, I'll show you that picture here, there's the conservative on the right, 90% of those patients were treated conservatively in the control group, whereas 51% were treated with ablations. And the VLU healing rate at 12 months in that group was 81%, compared to the other groups. The control group with ulcer healing was 21%. So that definitely proves that this accelerated pathway training and understanding your referral system and how to proceed quickly rather than delaying treatment does affect ulcer healing rates and therefore costs. And I hit it right on target there. All right. That's it. Thank you.
So thank you, Zoe. So we are privileged that our next speaker, Dr. Alan Davies, who is a professor of vascular surgery at the Imperial College of London and probably one of the world's leading, and I mean globally, he's internationally known for his expertise in venous disease and evidence-based medicine. He's also one of the principal investigators on the EVER trial. He has graciously agreed to give us a talk about whether or not we need more clinical trials for venous disease. He's going to be giving this talk remotely, so hopefully he's joined us and is ready to go. Hi, Alan.
Sorry, Peter, I'm just having some difficulty getting the slides up.
Oh, there you go.
Okay. I'm just checking that can you hear me?
Yes, we can hear you.
Yeah. I may have to ask you to move the slides on, but thank you very much for the opportunity to be able to talk to you, and I'm sorry not to be there in person. And I will be slightly reduplicating some of the talk that the previous speaker gave. But I think I just wanted to highlight some key issues about leg ulceration. And this is basically to highlight actually healthcare usage by people who have chronic venous disease, and particularly those with C5 and C6 disease. That certainly in a study that we've done in the UK, they see and go to primary care and community nursing about 6 or 2-fold more often than patients without venous disease. Next slide, please. If we then look at the usage of accident and emergency or non-elective hospital admissions, you can see here very clearly that if you have got chronic venous disease, you are 3 or 4 times more likely to use A&E or a hospital service. So this has significant impact on budgets. Next slide, please. And then the other thing, and this data has also been confirmed by some of our Dutch colleagues in their study, that has also shown that there is a significant higher cardiac event rate and all-cause mortality in people who have C4, C5, and C6 disease. And from our data, you can see that if you have got a venous leg ulcer, your mortality rate is significantly greater at 11 years than for people who do not have venous leg ulceration. Next slide, please. Carry on. And one more. The important thing is that by a lot of healthcare professionals, this is an sort of glamorous disease process, but actually causes, and certainly in the UK accounts for anything up between 2 and 4% of the usage of the healthcare budget. Next slide, please. We've heard about compression, and we know that compression is undoubtedly the mainstay of the initial treatment in the community. Next slide, please. The one thing that, and we've heard about the European guidelines, but the one thing that is actually very clear, that we actually tend to ignore most of the data. That certainly if you look at the Cochrane review that was done in 2007, there is really very good evidence base for the use of pentoxifylline, but certainly in the UK and certainly around most of Europe, it's not used. Aspirin, and looking at the latest New Zealand data, there really is no benefit. If we look at the Taiwanese experience, there certainly is evidence to suggest that statins may be of benefit, and we've already heard that in mainland Europe, MPFF is used and it's now available in the States. Next slide, please. There certainly is no evidence to suggest that skin grafting or any skin substitutes are actually of any benefit with respect to venous leg ulcer healing. Next slide, please. If we look at a review that we did in 2008, and this was just after the ESCAR trial had been published, the Van Gent study had been published from Holland, and we published a small study, and that's known as the GUEST study. It was very clear that these studies all suggested that healing was not improved by venous superficial intervention, whereas recurrence was. Next slide, please. However, all of the studies prior to 2000 actually showed that surgery, patients who had surgery did much better than those treated by just compression alone. And it may be that things like the ESCAR trial have actually held back the management of patients, and we'll come on to talk about that a little bit more. Next slide, please. This is the ESCAR trial, which was very much held up as being the landmark trial that showed very clearly that healing was improved by the intervention on superficial vein incompetence. However, no benefit with respect to healing. And the issue really here is whether that was because all comers, there were a number of patients who actually did not actually end up having their treatment. But it is quite important because this has certainly influenced practice significantly in the UK, such that patients were often told that they shouldn't have their intervention until their leg ulcer had healed. Next slide, please. You'll all be familiar with the old AVF recommendations, and these were very much attributable to the ESCAR trial. Next slide, please. Then there were a number of studies that were conducted, and cohort studies, that suggested that actually by using foam sclerotherapy, there was some benefit with respect to leg ulcer healing. Next slide, please. This was also a study that we did looking at a cost-effectiveness analysis, even on the superficial venous reflux with traditional surgery, but this did suggest that it would be cost-effective to intervene on veins. Next slide, please. This led us on to go and perform the EVERA trial that you've already heard about, but very clearly the main things about the EVERA trial are that, one, it accelerated healing, it reduced leg ulcer recurrence, and it was undoubtedly a very cost-effective way of treating patients. Next slide, please. You've already heard that this has now led to 1A and 1B recommendations with respect to the ESVS guidelines. Next slide, please. But, and I think this is quite important, is that while we talk about EVERA being early intervention, when these patients were actually intervened on, they had actually had their leg ulcer present for 3 months. And I would like to suggest that we might even get better results if these patients were seen within 2 weeks and maybe treated much earlier. Next slide, please. Certainly in the UK, this has led us to an RSM recommendation that patients should be referred within 2 weeks. The government have even taken this on board. And next slide, please. There was been a very important development called the National Wound Care Strategy Program that has led to the development of a sequin. And a sequin is basically where you either get rewarded financially or fined for not delivering that care. And the new recommendation is that if you are in the community, within 2 weeks, you should refer patients to a vascular specialist for assessment. Next slide, please. Here is some data with respect to issues with respect to post-EVERA. You can see that in the UK, it certainly takes around about 6 weeks to see a specialist, then 4 weeks to get the procedure, and EVERA probably changed people's practice in about 30% of the time. Next slide, please. If we looked very closely, only 20% of people felt that there were no barriers to actually introducing a 2-week service. The majority was because of a lack of capacity, either be it operating theatre or office space, to be able to intervene on these patients. Next slide, please. So overall, when we looked at primary care, i.e. because most patients in the UK have to go through a community doctor first, 28% felt there'd been no particular change. Next slide, please. Whereas 60% felt that there were significant barriers to them actually implementing any changes. Next slide, please. I would very much like to think that we should all very much like to adopt this potential global pathway that from diagnosis to venous intervention and then long-term compression should occur in a 2-week period. We seem to manage a 2-week pathway when we're talking about the delivery of care with respect to cancer. Next slide, please. So what are the main issues? Those are of implementation. Next slide, please. You have already heard about the LUPA trial, which in a way has seen the development of leg ulcer services, but in a way is, in the UK, is reopening what we used to do 30 years ago that then got closed down for various reasons of funding, but it has really emphasized the importance of having a very clearly defined pathway. Next slide, please. Where are the blockages? Well, they are multifactorial. They can either be educational, systems failure, lack of facility, or cost. But the real thing is that if you actually treat these people early and you leave them ulcer-free, you are actually saving your healthcare budget a significant amount of money. Next slide, please. We also need to agree that the guidelines worldwide are all in agreement, because there are a variety of guidelines that are made by this organization or that organization, and we do need to have clarity of thought. Next slide, please. So I'd like to suggest to you that we need to have early referral and early treatment to avoid a chronic leg ulcer. Next slide, please. Now, I've very much given you the evidence with respect to EVRA and ESCAR. Next slide, please. And yes, early intervention would seem to be better. Next slide, please. In the UK, we are just in the middle of looking at a major venous leg ulceration platform study. This has been called for by the government, but it's because various things such as the James Lind Alliance and the government and the National Wound Care Strategy Programme have highlighted the issue. And I would just like to remind, and some of you in the audience will remember being in Hawaii in 2009 when there was a call to arms to reduce the incidence of leg ulceration by 50% within 10 years. And I have to say we have absolutely failed. Next slide, please. So we have been fortunate in the UK where got through the stage 1 of a bid, and we're waiting to hear, and we're just putting the application in for the stage 2 of the bid. The government have come out with a call for platform trials, and one of the successful bids was that for looking at cohort of patients with venous leg ulceration. Next slide, please. Now, within this bid, and when we were reviewing and doing all the various bits of scoping and scoping, what are the areas that we could do research in with respect to post-ESCAR and post-EVRA? Well, it could be on service organization, conservative treatment, looking at the role of compression, and certainly looking at the role of exercise. We heard in the previous talk that there's no randomized control trial looking at the benefit of exercise and mobility. What should we do to prevent leg ulceration? Yes, compression hosiery, but are there any drug therapies that might be of benefit? Interventionally, what could we do to the wound itself? And what should we be doing with respect to either the subdermal plexus, the iliac system, and deep vein reconstruction? We've talked all about the medicines and various other things. So I think with the last talk and my talk, if we go to the next slide, please. It is very clear that the answer to the question that I've been asked is that there are far more questions that need answering than we actually have answers to. So thank you very much, and I apologize for the slightly disjointed way of having to ask for my slides to be moved on. Thank you very much.
So thank you, Alan. If you could just hang on for the question and answer section in a few minutes. I got a message that our next speaker, Dr. Ulloa, who is also a remote speaker, hasn't logged on yet. Is that correct, Max? Because if that's the case, then we're just going to skip the talk and we're going to go straight to the QA session. So can we please have the table that's off there to the side brought up onto the stage along with some chairs? And let's have our speakers join us for a quick question and answer session before we go. We have a lot of time for a QA. And by the way, if there's any questions from the first session, please feel free. We'll have the microphones passed around to the audience so we can have that discussion. Thanks, guys. So, all right. Let's see, are we good? Yeah, so Jose, if you please join us. All right, so I'm going to start with you, Alan, since we have you here. So if you were to design the next clinical trial for venous ulcer disease, what would you focus on as being the primary and secondary outcome measures?
With respect to the primary outcome measure, undoubtedly it has to be leg ulcer healing. Because I think the straightforward answer is, even though with all the large trials we set up to do quality of life measurements and things, I think the key thing is that you need to have a leg that is ulcer-free. Because we know very clearly, and there are enough studies out there to show that if you can get somebody free of their leg ulcer, their quality of life significantly improves. And then with respect to recurrences, again, it is a leg that is ulcer-free.
Yeah, I would like to see a little bit more diverse patient population as well. Most of the clinical trials on venous ulcers have been in Caucasians, and there's a lot of good retrospective data to show that depending upon your race, you may actually behave differently. So, and I'd also like to see larger ulcers involved in the trial. If I'm correct, the average ulcer size in the EVRA and ESCA, the ulcers were like around 3 centimeters, and many of them even healed with compression before they got randomized. So I think a little bit larger, maybe a more diverse population is something that I would like to see in the next trials. So
I think that's inordinate. I would completely agree with you. And the platform trial that we're just completing the bid for, we are actually also going for large chronic venous ulcers that have been present for more than 6 months.
Awesome. So my next question is for Jose. So your review of kind of where we were from the early 90s in the basic science to the development of these models was fantastic. But when Nikos showed that model of the cast that had turned, of the microcirculation attached to the saphenous vein, it really emphasized to me some of the work that I'd done earlier. So Jose, other than destructive technologies, which is kind of what we do if you think about it, are there any potential therapeutic technologies? Because when I saw that cast, I immediately thought about embolospheres or some of the new delivery methods that we could use to maybe target certain pathways. So what are your thoughts about therapeutics based upon the work that you've done in the models?
Well, first of all, thank you for inviting me and for the question. I think it's a complex situation, and I think all of the speakers and your contribution when early work, it's clear that it's a very complex situation. I like that if we try to match the clinical perspective with the studies at the molecular level, in the prevention of the ulcers, for example, compression could be key. And I try to go from the simple to the more complex. It's true that extravasation of red blood cells initiate all of this cascade that it was proposed. I think compression therapy can prevent to at least reduce that iron overload in the area, which I think is one of the mechanisms that initiate that. Now, if you think down the road in the different mechanisms that we understand today about ulcer and healing process or delay healing process, any therapeutic that ameliorate the inflammation and try to modulate the action of the fibroblast, I think could be important. Now, it's true that inflammation is needed, but I think it's the modulation what we need to think about, I mean, in terms of efficiency for the future. But I will stop here.
So my next question is for Dr. Labropoulos. Nikos and I have spoken for many, many hours about obstructive lesions and whether or not IVUS is the appropriate technology to diagnose an iliac lesion, and he's actually encouraged me, during my venograms to make sure the patient's properly hydrated, to do the Valsalva maneuvers, and I've started to incorporate that in my practice, and I will say it's made a difference. I recently did a case last week in which I had a woman in her 30s. She was dehydrated. On the initial IVUS, it looked like it was a significant stenosis. After hydration and Valsalva, it went away completely. Then with a more thorough examination and venogram, she actually had an isolated right ovarian vein reflux into a pelvic reservoir. So if we had just stopped at that initial IVUS measurement, probably wouldn't have gone and found what was really the cause of her problem. So Nikos, I know you've done a lot of work about this. You feel pretty passionately about this topic. Can you talk about a significant iliac vein lesion for us a little bit?
Yes, Peter, I'm going to talk about it later in this program, but briefly, we just finished a study a few months ago on prospective of 100 people with appropriate signs and symptoms, and we found that if you have a non-thrombotic iliac vein stenosis, where you stand the patient, 2/3 of people do not have a stenosis on the standing position. And to me, like on your patient you just said, it's important because then we define criteria to whom we should treat, and then if there are other reasons that the patient has a problem, and treat the real reason. I'll stop with this because we'll talk a little bit later in more detail.
Okay. I'm going to ask Zoe a question, then I'll open it up to the audience. So Zoe, I'm sure when you review these guidelines, I have to say I'm normally not a fan of guidelines. And Alan and I have had these discussions about them. But I thought that this last iteration from the Europeans was actually very, very well done. And I was really impressed with their algorithms, their shared decision-making models. And then they had a whole if you haven't read this document, I hate reading guidelines, but I actually read this one. The Venus also one is very, very, very well written. So Zoe, what were your feelings about the updated guide? Because you had mentioned that the AVF hadn't done this, what was it, 2014 was the last one? It's been 10 years. And then this one was published in 2022. Did you notice any updates,
Yes,
any changes?
Yeah, the biggest changes, I think, were the recommendations on the Deep Venus system, which I think were more specific on the updated European guidelines, and also the use of compression, both short-term and long-term, being specific to the inelastic and the short-stretch garments. The pharmacotherapy, we always have, they have more than we have here, so I think it's great for us to look at that and research that. But those were the big points, I think, the highlights with their updated guidelines, as well as the early intervention. Now, and that was different from the U.S., but I had a question both for Nikos, if that's okay, and Dr. Diaz. But both of you mentioned the microcirculation, the insufficiency in the microcirculation. We see that there are studies that show that in obesity patients alone, without any axial vein disease, any deep vein disease, it is just specifically microcirculation insufficiency causing the hyperpigmentation and skin changes in obesity patients. Are you aware of any studies showing any kind of treatment of that?
No treatment targeting the microcirculation with destructive technology, like Peter said. I mean, what Peter said, it's fascinating. I don't know if it could be tested, but the thing is in the people who have ulcer or those about to have an ulcer, if you can do such a therapy and never develop an ulcer. But this has to be done, never be done, And also we need to find out good ways in vivo of how to find what area suffers and how much, so you target the area of treatment.
So an imaging technology
Yes.
that you can do live. I'm sorry, imaging technology, yeah.
There is such a thing now, but it's not adopted. You can use, some of these new techniques, where it can, is not for routine clinical use because it takes a longer time, but you could at least start with technology like that to demonstrate that there's an issue. Maybe do a study, and if it does, then probably techniques become faster and better and have,
Yes.
more targeted treatment.
Right, because it also can happen with straightforward lymphedema. So you see the same type of thing. So there's a big opportunity, I think, there to target those two populations without vein disease.
Okay, so let's take some questions from the audience. Dr. Soufian, I see you're itching to ask us something.
Thank you. My question is to Dr. Diaz. Jose, in your multiple previous works that we have kept up with, you had written a lot about the association of inflammation to the process of thrombosis and the so-called immunothrombosis syndrome.
Yeah.
Now that
Shakib, can you get closer to the microphone? We're having trouble hearing you.
I'm sorry.
Yeah, just lean in a little bit.
Shall I repeat? Jose, the question I have is, in your previous work, we had written a lot about inflammation as part of the process of thrombosis, and it was at one time termed as immunothrombosis even. And there you even showed P-selectin and things like that may be effective, if I remember correctly. Now that we have these animal models, have we looked into tie that up, and if there any effect on cutting the inflammation to affect the thrombosis?
Thank you for the question. Yes, the models will help for future therapeutics. I mean, knowing what the animal model can offer, we can really answer some questions. For example, new treatment, new drugs. That can be studied at a level. Now, we need to keep in mind that even though animal models are out there to help to understand us and to test new compounds even before we go to clinical trials, they have their own limitations. Most of the animals that I mentioned are quadruples, so they the way that the physics works in circulation with this anti-gravitational situation that Homo sapiens we have, that it can be reproduced unless research is performed in monkeys. So what we need to be careful, I mean, we can be excited. I'm very excited about the future. However, we need to be very careful in how we apply each of the animal models that we have, depending on the research question that we have. And I think that is the way to go. But yes, very promising. And sometimes we need to combine different animal models to answer one research question. So that is also what we need to keep in mind. No, one doesn't reproduce the disease exactly. In fact, they are healthy animals. So, but thank you for the question.
So as you know, we're also live streaming this. So there are 2 questions from the virtual audience. One is from Jordan. He says, Dr. Pappas, how do we get rid of this 3-month conservative measure of stocking usage prior to the treatment requirement of insurance companies? Well, if I knew that, I'd be retired and sitting on a beach in Florida someplace. So, I mean, I think we all know that what the reasons for this 3-month requirement is. Most of the insurance companies know that a good 30 to 40% of people who have to do a 3-month stocking trial aren't going to return, you know, because so this is a way to kind of weed out the people who really are symptomatic. I really don't see this as ever going away. Maybe it might be limited. I know in the United States, I will tell you that depending upon the state that you're in, the region, it varies from 3 months to 6 months. So some insurance companies don't even have the requirement. So, you know, it took 16 years to get the Lymphedema Reduction Act passed, and even with the Lymphedema Reduction Act, there is a requirement for demonstration of compression therapy. So I think we might see this policy modified. I personally don't see it ever going away completely, but you know, I think this is a way to kind of reduce access to care.
Peter, could I just pass a comment? And I know you don't like guidelines, but the NICE guidelines from 2013 were very clear that compression hosiery should not be used in people who would be suitable for a superficial vein intervention. And I just think it's a drum that needs to be beaten a bit more. And certainly in the UK, that is what we try and adhere to, is not get people into compression hosiery, because I'm going to pose a question to the audience. I do not know of one study that suggests that the use of compression hosiery in C2 patients is of any clinical benefit. If anybody knows, can they please drop me a line, and I would love to have that study.
No, listen, I think there's no question that compression therapy doesn't cure or prevent anything. It just manages symptoms. But this is an area where clinical knowledge and government policy conflict, because there's funding involved in all of it. So I think you have an advantage in the UK in that there's a heightened awareness of it, whereas in the United States, there's some resistance to it. So I think this is a conflict between policy and medicine. Anybody? Yeah, go ahead, Zoe.
Yeah, I think one way to attack that is just what we were saying about the early intervention, at least in the ulcer patients. If you're showing that 2 weeks or intervening at 2 weeks is going to save you how many millions of dollars, I think dollars is where you get the attention of the insurance payers. So that can be one step to getting us towards showing the insurance payers that if you're going to delay our treatment by 3 months, when it clearly shows that we have improved healing if you intervene at 2 weeks, that's one way to get started.
Yeah, I think if you want real policy change, one of the things I've learned over the past couple of decades, especially from the Lymphedema Reduction Act, the federal government in the United States responds to advocacy groups and populations. So if there is a large patient population that will benefit from a federal program, that tends to move the needle a little bit. So there's a second question from the audience. This one's for Dr. Diol. Given that obesity is an important and increasing factor in vein disease, do you see weight loss management and/or the offering of semaglutide or tirzepatide injections as part of venous and lymphatic clinical medicine, assuming the physicians and nurses are educated properly about the pros and cons?
100%, and it is 100% part of my practice, and every single patient gets a discussion on BMI when they come in, and just like, I forgot who pointed it out, but I think Nico's pointed it out, if a patient comes in and their BMI is over 46 and they've got an ulcer, I'm going to be treating them to heal the ulcer, to get them mobile, but all patients of mine that are BMI of 40 or higher get referred to a medical weight loss clinic. And that is part of the treatment. It shouldn't be left out at all. And you would be surprised. I get a lot of questions about how does that go down when you talk to the patient. And I would say 98% of patients are grateful that I brought it up and are happy to talk about it and are glad to get help. So yes, I believe it's 100% part of that.